Hello everyone. Today in this video we are going to discuss about approach to a child with congenital adrenal hyperplasia. This is the most common cause of female pseudohermaphroditism. So a congenital adrenal hyperplasia is most common cause of female pseudohermaphroditism. It is an MCQ. First. Second MCQ is it is the most common cause of female ambiguous genitalia in children. So it is one of the most common cause of female with ambiguous genitalia, and it is an MC also a MCQ. So it is one of the most common cause of non-cardiac shock in children with in neonatal period. So it is very much important to know about this congenital adrenal hyperplasia. As the name suggests, there is a congenitally deficiency of the adrenaline hormone production, and that's why there is a hyperplasia of the adrenaline gland. So, what are the different hormones is released by the adrenaline gland? So, adrenaline gland release three major hormones, and the most important hormone is cortisol. That means steroid. The steroid is most important hormone that is released by the adrenaline gland, and this hormone is causing maintenance the blood sugar level and also maintaining the blood pressure. So when there is a deficiency of this cortisol hormone, so blood sugar is going to decrease and also the blood pressure also going decrease, and there is a plenty of other problems is happening in the body. So this is a major hormone that is decrease synthesis in case of congenital adrenal hyperplasia. The second one is the mineralocorticoid, that means cortisol. This hormone is mainly maintaining the electrolytes in our body, that means maintaining the sodium, maintaining the potassium and hydrogen ion in our body. So when there is a decreased amount of this hormone, so there is a release of this hormone from the kidney and causing decreased sodium and increased potassium, and there is a decreased blood pressure. So this hormone, cortisol hormone, is mainly maintaining our blood pressure and also maintaining the electrolytes and causing and maintaining our pH also. So when there is a problem is this, there is a metabolic acidosis is also there. And the last hormone is androgen hormone. So this hormone most of the time is not synthesized and most of the time it is over synthesized. So what are the causes in which there is androgen hormone is over synthesized and low synthesized, I will discuss later on. So this androgen hormone is mainly doing the secondary sexual features production. So this androgen hormone is mainly appearing the secondary sexual features in case of male and also the female. So the secondary sexual features are, that is muscularization. That means all the muscle overproduction it is done by the androgen hormone. Also, there is a pubic hair growth, there is a mustache, and there is a formation of underarm odors and also underarm hairs. These are the features in case of male androgen secondary sexual features. The female secondary sexual features are production of pubic hair, production of breast, and maturation of the breast follicles, and also the underarm odors and also the hair. So these are the secondary sexual features in case of female. So when there is a overproduction, these features will increases, and there is a underproduction, the features will not appear. And also this androgen hormone by this androgen hormone also leads to production of testosterone and estrogen. Testosterone hormone is also very much important for the male, and this estrogen hormone is also very much important in case of female. So these, when there is a androgen is decreased, so there is a decreased production of testosterone in case of male. So there is a problem in the male genitalia, and if there is a decreased production of androgen and there is a decreased production of estrogen, there is a problem in the female. If there is a overproduction of testosterone, then female become male, and if there is a underproduction, then female having decreased their puberty and also genitalia features. So this is very much important to know all the three hormones. So in case of congenital adrenal hyperplasia, first there is a deficiency of enzymes. What are the enzymes? First we have to know the from the cholesterol all the hormones are released, all the hormones are synthesized from the cholesterol. This there is a production of pregnenolone, and from by the hormone by the enzyme of 3 beta dehydrogenase. These are the major hormone I will discuss on later on every hormone enzymes. So from the cholesterol it is synthesized pregnenolone, and from the pregnenolone it is progesterone. No need to memorize these things also. And from the progesterone it is deoxycortisone, then cortisone, and then lastly the aldosterone, that means cortisone. So the enzyme is 11 beta hydroxylase, 21 alpha hydroxylase, 18 hydroxylase, and 17 alpha hydroxylase. These are the major enzyme which is produce the aldosterone, that means cortisol, and there is a 17 alpha hydroxylase which produce cortisol. And lastly, this hormone also produce DHEA, that means dehydroepiandrosterone, and from the androsterone there is a production of androgen hormone, and there is after that there is a production of testosterone and also estrogen. So this is the pathway in which there is a production of cortisol and androgen hormone, also the sex hormone. So if there is any problem in these enzymes and this pathway, so there is a this is called CAH, congenital adrenal hyperplasia. So firstly, I have discussed the most common enzyme in which deficiency there is a production of congenital adrenal hyperplasia. Most common type is 21 alpha hydroxylase. This enzyme. So 21 alpha hydroxylase. As the 21 alpha hydroxylase enzyme is deficient, so there is a no production of mineralocorticoid, and also this 21 alpha hydroxylase is also need to produce steroid. So there is a decreased amount of mineralocorticoid and also decreased amount of glucocorticoid. So most of the cholesterol is going to synthesize DHEA, and from there is a increased androgen hormone and also estrogen and testosterone hormone. So this is in this case, that means 21 alpha hydroxylase the most amount of the hormone, most amount of cholesterol is produced androgen, excess androgen hormone, that means sex hormone is in produced, but there is no production of mineralocorticoid and glucocorticoid. As the mineralocorticoid and glucocorticoid is not synthesized, so there is in 21 alpha hydroxylase, so there is increased amount of androgen and the decreased amount of mineralocorticoid. So what are the features? The features is child is suffering from, so 21 alpha hydroxylase, the child is suffering from decreased cortisol and so hypoglycemia, that means decreased glucose in the body, and so child having hypoglycemia, lethargic, and there is a decreased blood pressure. Why? Because the blood cortisol maintaining the blood pressure. Also there is a decreased production of cortisol. So cortisol maintaining the electrolyte. So there is a release of most amount of sodium. So there is a hyponatremia is there and hyperkalemia is there. Why? Because the sodium is released and potassium is absorbed in the body, and there is a metabolic acidosis. So these are the features of cortisol, and there is a child is present with shock. And as the androgen hormone increase amount of sex steroid, that means androgen hormone. So in case of female, what happened? In case of female and in case of male, in male, first you have to know when the child is in the mother womb. After 6 weeks, there is a differentiation between male and female. Before that, the child is neither male or not female. This differentiation is done by the Y gene, and Y gene release some hormone. I will discuss in my next video which hormone causing which hormone produce which male or female. It will discuss on the later on some in case of DSD. But so for the male to produce male organs, because so all the primary male organ there is a need of testosterone, and for female the need of testosterone is 0. So no need of produce, there is a no testosterone, so that is why the female there is a female, and if the testosterone is there then it is male. So in case of CH, the female child, the gene is the genetically it is male, female, that means XX, but as there is an increased amount of sex hormone, sex steroid, so what happened? There is an increased secondary features of male, that means there is a clitoromegaly, there is a muscularization, then there is a labia majora and minora become hypertrophied. So it is called female pseudo hermaphrodism. But in male, as the hormone androgen hormone is much more, and as that means the testosterone hormone is increased, so the child is genotypically it is also female male, and female phenotypically is also male, but there is a chance of precocious puberty. So precocious puberty in case of male, the present male present with precocious puberty and the female present with female pseudohermaphroditism. That means the female is genetically female, but it is phenotypically looks like a male child. So this is the features of 21 alpha hydroxylase, and the child is present typically just 5 to 7 days after birth when the mother's steroid is decreased in the body. So before that, the mother steroid is transferred to the from the mother to placenta, mother to the child by the placenta. As the cortisol level and corticosteroid level is decreased, and there is no production of this hormone, so the child is going for in shock, and also there is a increased salt. This is called salt wasting, as there is an increased amount of sodium is going out, and that is called salt wasting shock. That means there is a really increased amount of lethargy and hypoglycemia is there. Child is in shock, and there is a profuse polyuria. And the in female, in case of female, so we are after birth we can see the female having ambiguous genitalia, and male it is normally. So when we found a patient in child that is ambiguous genitalia, always think about 21 alpha hydroxylase. And if we are not investigate the child before 5 to 7 days, then the child may go to shock. So always check the basic or do the basic investigation when you found a patient having ambiguous genitalia. Now, this 21 alpha hydroxylase enzyme have deficiency is three type, typically three type. First is the classical type, in which, as I said, there is a complete absence of this hormone. But in non-classic type, that means in non-classic type, there is small amount of production of 21 alpha hydroxylase is there, but it is small. So there is a presence of mineralocorticoid is there, and glucocorticoid is present to some extent, but most of them are produced androgen hormone. So the child is present, maybe not present after birth, after 10 to 15 days of birth with shock, as because the hormone is there, but the female child is present with ambiguous genitalia, and male child and the male child is present with precocious puberty on the on the puberty time. And in case of last, that is non-virilization type, that means there is a most of the production of mineralocorticoid is there, and there is a small amount of decrease of this. So there is an increased amount of cholesterol is going to produce androgen hormone. So there is a the female may have normal genitalia, but the features of muscularization and also the features of male is present in a female child at the. So the secondary features of male child may present in a female at the puberty time. So that means muscularization, the change of the voice, and there may be a mustache formation in case of female because of the increased androgen hormone in the puberty, and the male patient present with precocious puberty. So this is 21 alpha hydroxylase. So this is 21 alpha hydroxylase. Next is 11 beta hydroxylase enzyme. This is one of the important enzymes. 11 beta hydroxylase. This is the second most common enzyme deficiency, in which there is a decreased production of corticosterone, that means mineralocorticoid, and decreased production of steroid, cortisol. And there is a overproduction of androgen hormone. So it is similar, looks similar like 21 alpha hydroxylase, but the crux is there is precursors is formation of deoxycortisone and deoxycortisol, and this precursor is this deoxycortisone is similar to similar to like mineralocorticoid, but the deoxycortisone is not similar to function of cortisol. So there is a increased production of this hormone. So mineralocorticoid is excessive form, but the steroid is not there, and the androgen hormone is there. 21 beta hydroxylase, the child is having increased androgen hormone and increased mineralocorticoid, as the precursor of mineralocorticoid is just similar to look like mineralocorticoid hormone. So in 11 beta hydroxylase deficiency, there is an increased production of mineralocorticoid. So that means there is increased production of cortisol, and this cortisol produce increased sodium in the body, and that means the child having salt retention, as the sodium is getting retained, and the child having hypertension, the child present with hypertension, and as there is a decreased production of cortisol, that means steroid, as the decreased production of cortisol, so the child having decreased blood glucose. So the child present with decreased blood sugar, that means hypoglycemia, along with hypertension and salt fasting hypertension. And as the androgen hormone is increased, so the female is look like male. So there is a female is genotypically female, but it is phenotypically male, as there is an increased androgen hormone, and the male is present with it is genotypically male, but phenotypically also male, and the patient present with precocious puberty. So this is the 21 beta hydroxylase. So male is having pseudo hermaphroditism, female is look like male, but the male is having precocious puberty. Now the third one is 3 beta hydroxylase hormone. So this 3 beta hydroxylase hormone is very much important, as this 3 beta hydroxylase is not seen, enzyme is deficient. So from the cholesterol, the body cannot produce now neither mineralocorticoid, neither glucocorticoid, or neither the androgen hormone. So estradiol and testosterone is also not synthesized by the 3 beta hydroxylase and testosterone. But the precursor of androgen hormone is DHEA, that may having some androgen like property. So DHEA is having androgen like property. So the patient present with no mineralocorticoid, no glucocorticoid, and but increased amount of DHEAs, which is just similar to androgen hormone. So the patient having decreased sodium, increased potassium, decreased blood glucose level. So the patient having present with salt, losing, shock, and also hypoglycemia. And the female patient is female and male. As the male patient, as I said, need testosterone to produce their genitalia. So maturation of the genitalia of the male patient, as the testosterone hormone is not there. So there is a male patient is looks like female. So genotypically it is male, but it is look like female. But in case of female, as the testosterone hormone, there is no need of testosterone hormone, as the female each patient is presented with, it is genotypically female also and phenotypically also female, but as the androgen hormone is like increased, so there may be a ambiguous genitalia, or there may be as the DHEAS hormone is increasing, and it is patient may present with precocious puberty, and also the patient may present with secondary muscularization. So 3 beta hydroxylase, as I say, androgen hormone is decreased, but the DHEAS is there, mineralocorticoid is also decreased. So the patient present with salt losing, shock, and the male patient is just like female patient, and female patient is having normal in the birth, or the patient may present with some features of secondary in precocious puberty. Now the last hormone is 17 alpha hydroxylase, as this hormone is very much important to produce from the cholesterol to produce cortisol and also the androgen hormone. So as there is a decreased production of this hormone, there is a complete deficiency of this hormone. So all the cholesterol is going to produce androstenedione, that means mineralocorticoid, but there is no production of cortisol as well as no production of androgen hormone. So there is a increased sodium in the body, and there is a hypertension. The child patient is present with hypertension, as there is an decreased glucose level, that means salt retention type, and also as there is a no testosterone hormone, and also there is a no does not having produce testosterone hormone, and also androgen hormone is not there. So the male patient is look like female, that means male pseudohermaphroditism, and female patient is normal, and patient may present with there is, as the androgen hormone is not there, so there is a delayed secondary sexual features is there. So the female patient is present with delay puberty. So these are the features of 17 alpha hydroxylase. As I said, 17 alpha hydroxylase, there is a decreased androgen hormone and increased mineralocorticoid hormone. Why these hormones are increased? Because the treatment and also the enzymes are very much so why these hormones are very much important to know? Because the treatment is based on the hormonal therapy. Now the investigation. So when we are found a patient present with ambiguous genitalia or the patient having shock, suddenly newborn going to shock, so always do the blood sugar test to see the blood sugar. If the blood sugar is decreased, and also do the electrolytes and ABG. If the sodium is also decreased and potassium is increased and ABG showing metabolic acidosis, always think about the child having, there may be a patient may having CAH in male patient also, and also the female patient. Female patient always check the genitalia. If the genitalia showing there is clitoromegaly or there is a labia majora or minora getting hypertrophied or pseudohermaphroditism, and male patient the genitalia is quite normal, so it is quite impossible to diagnose male patient by seeing the only just genitalia. Then all do this investigation and also the routine urine examination, urine test, where it is shown that the child having in polyuria, and so the osmolarity is decreased. And the lastly, if you suspect the child having this type of CH, always do the enzyme assay. Enzyme assay is the typical investigation of choice. And for the 21 alpha hydroxylase, there is a we have to do investigation. We have to do 17 hydroxyprogesterone level. We see the so this hormone, this enzyme we have to see, as because there is a decrease of this enzyme, as there is a deficiency of this enzyme. So the precursor of for this, it is 17 alpha progesterone, and we have to assay this enzyme. So we have to assay that this enzyme, if this enzyme, this hormone is getting increased, so think about CAH. And also after that we have to confirm by giving ACTH stimulation test. What is ACTH stimulation test? We take serum cortisol level before giving ACTH, and also the 17 alpha progesterone hormone level. After taking the base, this is the basic hormone level, and after giving ACTH hormone, we take a pause for 30 to 60 minutes. After 30 to 60 minutes, we again take blood sample to see the level of cortisol and also this hormone. If case of CAH, that means this hormone deficiency, this cortisol is decreased, this cortisol is level is decreased, but this 17 hydroxylase progesterone level is high. So ACTH is mainly stimulated to produce cortisol. If the ACTH, after giving ACTH, the level of cortisol is not increasing, that means there is a CAH. So you have to do the cortisol ACTH stimulation test to confirm the diagnosis, and after that the genetic study to see the CYP21 P gene and also CYP21 gene. These are the two genes in which there is a mutation causing 21 alpha hydroxylase deficiency. 11 beta 11 beta hydroxylase deficiency, we have to do the enzyme assay of deoxycortisone level. And 3 beta hydroxysterol dehydrogenase deficiency, we have to do the ACTH stimulation test, and we see the level of 17 alpha progesterone, also deoxycortisone level. And 17 alpha hydroxylase deficiency, we have to do deoxycortisone enzyme assay. So these are the investigation of choice. After that treatment, when the child having 21 alpha hydroxylase, as there is a complete deficiency of these two hormones, that means steroid and fludrocortisone, so we have to give these two hormones for this child. And as there is a excessive sex hormone, this hormone will also decrease the production of ACTH hormone from the brain, and so this is the main enzyme in the hormone therapy is needed. And 11 beta hydroxylase, the as there is a increased amount of fludrocortisone mineralocorticoid and there is a low amount of hydrocortisone, so we have to give hydrocortisone. As there is a hypertension, so we have to decrease the hypertension by giving the spironolactone. So this is the investigation choice. 3-beta hydroxylase, as there is a overproduction of mineralocorticoid and there is a less production of hydrocortisone. We have to give hydrocortisone and we have to negatively decrease the production of mineralocorticoid by giving the flutocortisone to decrease the ACTH stimulation. And 17 alpha hydroxylase, flutocortisone and hydrocortisone is the drug of choice. So we have to give this. So this is the treatment of choice. And when the child is present with shock, always we have to treat the shock with giving NS bolus and also giving hydrocortisone and flutocortisone.